Good evening. It is my pleasure to welcome you to the ORNAO webinar series this evening, sponsored by Johnson & Johnson. We have two guest speakers with us this evening. Dr. Wheatley is an internationally renowned specialist in aortic surgery and endovascular aortic repair. Dr. Grayson Wheatley is an expert in the management of aortic dissections and aneurysms. He's also a highly experienced board-certified heart surgeon who is committed to offering patients advanced open surgical and innovative endovascular treatments of complex aortic diseases, including aortic aneurysms, aortic dissections, pseudoaneurysms of the aorta, intramural hematomas of the aorta, aortic coarctation, and penetrating aortic ulcers. He is also involved in transcatheter aortic valve replacement, or TAVI procedures. I want to work in your operating room. That sounds really amazing, Dr. Wheatley. We also have Dr. Liza Ovington, and she holds a PhD in organic chemistry from Duke University. She is board certified in wound care by the American Board of Wound Management and is a fellow of the American College of Clinical Wound Specialists. She also holds certification in medical writing from the American Medical Writers Association. Liza joined J&J in 1986, where she led product development teams in consumer wound care. In 1991, she left J&J to pursue research in wound healing and infection control at the University of Miami School of Medicine. After further work experience in home healthcare and independent wound management consulting, Liza rejoined Johnson & Johnson in 2004. In the medical affairs for 16 years. She retired in late 2020 and is currently back as a consulting medical director for wound closure and healing. We're very excited to have both of you here this evening to present to our membership. Just a very quick note in terms of the format this evening before we hand it over to Dr. Ovington to start, and Dr. Wheatley will follow. We'd ask all attendees to please put all of your questions in the Q&A box. So note that there is a Q&A box on the very bottom of your screen, right next to the chat box. So please select the Q&A. We will hold those questions until the end of the presentations, at which point we'll be happy to explore all of those answers and have a dynamic discussion. At this point, again, we would like to thank Johnson & Johnson for funding tonight's event for our members, and I'd like to hand it over to Dr. Ovington. Thank you very much.
Thank you very much, Denise. I'm going to put my slides up, and I just need a verbal confirmation, if you could, to let me know that you can see them. Let me go into presentation mode. Oops, need to get to...
Looks great.
Great. So it's my pleasure to join you tonight and talk about surgical site infection and talk about the risks and the role that antibacterial sutures can play in managing some of those risks. And I tend to call antibacterial sutures an invisible weapon in the battle against surgical site infections. And hopefully that'll become clear to you as we move through the presentation. And in terms of moving through the presentation, the topics that I'm going to cover tonight is just briefly talk about the incidence, cost, and consequences of SSI, just to kind of level set us all, then start focusing in on SSI risk factors and the role that suture plays in SSI risk, which will lead us into a conversation of plus antibacterial technology, how that came about, moving into some of the clinical evidence for the efficacy of antibacterial sutures in SSIs, and more recent evidence on outcomes of incorporating antibacterial suture technology into SSI bundles. I do have some polling questions throughout the presentation, so we're going to have some technology interspersed in here and do a little bit of voting. But let's get started and just, as I said, level set about the incidence, cost, and consequences of surgical site infection. Now, I did try to find information on the burden of HAIs in general, or SSI in particular, in Canada, and I didn't find anything robust. So I am presenting US data because it is one of the most robust studies that I've seen, and I'm not sure that there's significant differences across countries, especially between the US and Canada. So this is a paper that was published in 2022. It came out of Stanford. And what the group did there, Dr. Forrester and his team, they did a retrospective analysis of one of the largest US inpatient databases. It's called the HCUP database. And what they did was they mined this database for any encounter that had a primary or secondary ICD-10 diagnosis code for any of the top 5 healthcare-associated infections: CAUTI, CLABSI, SSI, VAP, and C. diff infections. And when they got that incidence data, they combined it with the most recent data on the additional cost to manage those HAIs to create some burden information. So just briefly, what they found was that SSI accounts for almost half of all the HAIs in that database. A little bit surprising to me, maybe it shouldn't be, but that C. diff infections were the second highest, followed by CLABSI and then CAUTI, and VAP is on there. It shows as 0% because it's less than 1%, so it showed up as 0. So that's kind of where we are with HAIs at the primary diagnosis. And if you add in the secondary diagnoses, it really didn't change that much. Now, when you look at the additional cost of managing an HAI, the average cost for each type is shown here. And while surgical site infections aren't the most expensive, they're still pretty darn expensive at about $28,000. That includes the direct cost, readmissions, additional length of stay, all those parameters. But when you add that incidence and the cost, what we find is that the US, even in recently, is spending almost $4 billion a year in managing SSIs, many of which could be prevented. So it just tells us that there's more work to do, both in terms of technology as well as in terms of deploying our bundles and maintaining surveillance and adherence to the bundles that we put together. And we all know that there's also patient consequences to SSI. Aside from the costs that we talked about to the healthcare system, patients who sustain a surgical site infection are more likely to spend time in the ICU. They're more likely to be readmitted to the hospital. They have a higher risk of death, and they spend an additional week to week and a half in the hospital. So not to mention the impact on their life, their livelihood, their families, and those sorts of things. So there's more work to do. And when we do that work and we try to identify and address SSI risk factors, really want to talk about the role of sutures. Now, we're all familiar with kind of the standard risk factors, many of which have tend to fall into categories of likelihood of bacteria presence, as well as the ability of the patient to mount a robust infection response. So we know that the patients come with certain risk factors that we can't do anything about, like obesity and diabetes, but we know that prolonged surgery is a risk factor for SSI. Emergency procedures are riskier, and we do know that there are the 4 surgical wound classes: clean, contaminated, and dirty, which carry their own differential risk for SSI. And a lot of the things that we do have to do with reducing the potential for introducing bacteria by making sure we have sterile environments, sterile instruments, prepping the skin of both the OR personnel, the patient themselves, maybe having the patient do pre-op bathing or nasal decolonization prior to surgery. We, in many surgeries, we use antibiotic prophylaxis and different things like that. But I want to really talk about a ubiquitous and inevitable risk factor for surgery. And unless you're doing note surgery, there's 2 of those. And again, they're ubiquitous and inevitable for surgical procedures. And the first risk factor occurs when we make that surgical incision because we've breached the skin barrier. And we know there's a lot of things we do to prepare the skin, like I've already mentioned: skin preps, we glove, we gown, we do those things to try not to introduce bacteria into that breach that we've created. But the second risk factor comes at the end of the procedure, and that's when we close the tissue layers that we have disrupted with suture. And currently, that's all we have to close the tissue layers with, unless we're talking about skin, where we do have some options with staples and topical skin adhesives. But the suture is in and of itself a risk factor for surgical site infection. It may not be alone. If it were the only risk factor, it may not be enough to sustain an infection, but it definitely adds to the mix, and it's always present. So the first polling question that I'd like to put out there and ask you is, do foreign bodies or implants reduce the infective dose of bacteria required for clinical infection? Meaning, does it reduce the amount of bacteria that's going to cause an infection? And if you think it does, by how much? So we've put the poll up. We're going to ask you just to quickly vote, and then I'll tell you what the right answer is. So here we go. I see the numbers coming in, and we've got a good number of people. We got 30%, 31% saying it doesn't reduce the infective dose. And then we've got people saying that it does, and by a factor of 10,000. So we're pretty equally divided on the no, not at all, and yes, by a factor of 10,000. So actually, the right answer is by a factor of 10,000. So that is one of the features that led to the development of antibacterial technology. So the first piece of evidence that we have, and I'm not sure how to get rid of that poll now, if we could take that out. It's right in the middle of my screen. If Troy, if we could get rid of that, that would be great. But the first study that actually showed us that sutures reduce the infective dose by a factor of 10,000 was a study back in 1957 in the UK. And this was a study where they were actually trying to create infections in young, healthy volunteers. And they tried all different ways to create infections. And it was very difficult because these were young men in their 20s, and they had to resort to intradermal injection of millions of bacteria to create a clinical infection. But if they added a small piece of suture to the wound that they were inoculating with Staph pyogenes, was the organism they chose, then it only took hundreds of bacteria. And that's where you get that 10,000-fold decrease in dose, from millions down to hundreds. And I'm still not able to get rid of the poll in the middle of the screen.
Shouldn't be sharing. Is there a little X button in the top left corner of the poll option?
I can't access that. It's not, I don't have access. Oh, there it goes. I had to move it. Okay, great. So that's the study. And we won't be able to repeat this study in people because 1957 was before the Declaration of Helsinki, and I don't think we would get an IRB to let us do all the things they did in this paper. It's a very interesting read, by the way. It could be the script for a John Carpenter movie, if you ask me. He did some pretty horrific things to his volunteers. But one question you might have is, why does an implant lower the infective dose of bacteria? And if we think of bacteria as kind of the invading army and our immune system as the home team, and when I made this talk, I was very engrossed in Game of Thrones. So you see the army of the dead being the bacteria, and Daenerys and her dragons being your immune system. And they can typically do a pretty good job if you've got a robust immune response. But what that foreign body does, that implant, even if it's as small as a suture, even if it's an absorbable suture, the quickest absorbable suture that lasts maybe a week, that's plenty of time for bacteria to form a biofilm. And what the biofilm does is it's almost like the bacteria are creating a shield wall that can't be penetrated by your endogenous phagocytes, nor can it be penetrated by most antibacterial agents, antibiotics or otherwise. So the strategy would be to prevent them from going into that biofilm lifestyle. And in order to do that, you have to make the foreign body not be a hospitable place for them to land. So that's a fact. So that's known, and Ellick proved it. It's been repeated in animal studies, by the way. But we add to that fact some other facts. Additionally, knowing that implants lower the infective threshold. Also, we know that all surgical wounds, despite our best efforts, are easily contaminated with hundreds of bacteria by the time we close them. And additional facts, knowing that over 2/3 of all SSIs are confined to the incisional space, i.e. they're either superficial incisional or deep incisional SSIs, then that leads us to think that suture is that implant that we could do something about. We can't not use suture. We don't have any other options, but maybe we can make the suture not a hospitable place for bacteria to land. Now, you might say, well, where did those hundreds of bacteria come from? Because we did a skin prep, we had the patient bathe, we're all gloved and gowned, what's going on? It has all to do with the anatomy and physiology of the skin. We can only get at the bacteria on the top layer of the top layer of the epidermis, and that would be the top layer of the stratum corneum. There are plenty of bacteria in the lower layers of the stratum corneum, as well as on the epithelium that lines all the dermal adnexi, like sweat glands, hair follicles, and sebaceous glands. And another way I tend to visualize this is I think of one of my favorite desserts, baklava, with all those flaky layers of phyllo dough. At a macroscopic level, that looks almost exactly like a microscopic picture of the stratum corneum of the skin. So you can only clear or reduce the bacteria on the very top of this dessert. You can't get to the ones in the lower levels of the stratum corneum or around these hair follicles, et cetera. So when you slice into the tissue, you're freeing these bacteria, and that's easily hundreds of bacteria. It happens on all types of sutures, all materials, and all configurations of suture. Here's some scanning electron micrographs of chromic gut, silk, polyglycolic acid, and nylon sutures, all showing biofilm bacteria. And this was from an in vitro study where it only took 20 minutes for those biofilms to form. Here's this on the right, there's a study from 2013 where Dr. Edmonston from the University of Wisconsin explanted suture segments from about 160 different patients at different time points. And then he analyzed those suture segments for the presence of biofilm bacteria. And he found two important things. He found that in 100% of the cases that were infected, he found biofilm bacteria. And even in the cases that weren't infected, he found biofilm bacteria present in about 2/3 of the cases. Further, he found that the bacteria were equally present on braids as well as monofilaments. And that kind of dispels this illusion that a lot of people have that monofilaments aren't prone to bacterial colonization. They are just as prone to bacterial colonization as braids. So knowing that this affects all suture materials and all suture configurations, Ethicon started to think about what we can do. But one of the questions we have to say, is there anything else that we're already doing that can protect the suture from bacterial colonization and biofilm formation? So here's our second poll. There's two questions in this poll. Do you think that prophylactic antibiotics can protect the suture? And do you think that incisional wound irrigation with antiseptics can protect the suture from bacterial colonization and biofilm formation? So we'll start our poll. We'll see what you think. It's simple, true, false. Early on, we're seeing 50-50. Still hanging out at around 50-50. Give it just another couple seconds here. Yeah, we're kind of, I think we're hovering around 50-50. I don't think we're going to go much beyond that. So we're kind of equally divided on whether you think those interventions can impact or have an impact on biofilm formation. And the answer is actually neither one of them can. And real quickly, let's remember how prophylactic antibiotics get to where they're going in the body. They travel in the bloodstream. They travel through blood vessels. And at the exact place that we're implanting those sutures, we have cut all those blood vessels, which when cut, they retract into the tissue. The antibiotics cannot reach the suture. And they definitely can't reach it at a high enough concentration. If they could at all, it's not a high enough concentration to protect the suture. And the incisional wound irrigation, that happens before you place the suture. And so the suture is still that foreign body. And again, you're not getting at all those bacteria in those dermal adnexi. So there's nothing else that you're currently doing that addresses this particular risk factor, which is what led to Plus antibacterial technology. And I call it a 21st century solution to 3,500 years of risk, because we were using sutures 3,500 years ago, according to some Egyptian writings and papyri. And yet the solution, first antibacterial suture, which was Vicryl Plus, didn't come to market until 2002, the 21st century. And essentially what we're doing is kind of like this railing where the pigeons are very comfortable to land. You can make it uncomfortable by putting spikes on it. We kind of did that chemically with our sutures by making the surface of our sutures fight back. So it's not a comfortable place for bacteria to land and colonize. It's a technology that was available first on Vicryl, then monocryl and PDS, and now on our barb sutures. And it will be on any new suture that Ethicon comes out with, for the reasons that we'll cover in just a minute. Now, when we were deciding what to use, We purposely didn't go to an antibiotic coating. In the interest of antimicrobial stewardship, we wanted to reserve antibiotics for systemic use. So we went to antiseptics. Now, chlorhexidine is an antiseptic that you're very familiar with in the clinical setting, and Ethicon was very familiar with from another product that we make called BioPatch, a catheter site dressing. But we purposely said no to chlorhexidine gluconate as a coating for sutures because it's very much an equal opportunity antiseptic, meaning that it kills bacterial cells as well as human cells. And the last thing we wanted to do was coat our suture with an antiseptic that might have an impact on the healing cells. Sutures are supposed to help incisions heal by providing that mechanical support. So we didn't want to interfere with that the goal of the suture. So we chose an antiseptic that has a very unique mechanism of action called triclosan. And the way it works is it attacks an enzyme system in bacteria that doesn't exist in human cells. So it has little or no effect on human cells. So we use a pharmaceutical grade of triclosan. The trade name is Ergocare MP. And we were able to coat it on our sutures. We have a proprietary method to get it coated on our sutures. And we showed in vitro proof of concept. Here's the picture of the Petri dish where you can lay the antibacterial suture and a non-antibacterial suture. Then you flood that Petri dish with bacteria, and you see the red areas are where the bacteria grew throughout the agar as well as onto the non-antibacterial suture, but didn't grow on the plus suture or even anywhere around it. So we showed that testing proof of concept with the most common SSI pathogens, Staph aureus, Staph epi, the methicillin-resistant counterparts, E. coli, Klebsiella, and Enterobacter cloacae, which didn't make it on the slide. So the proof of concept was there. We could coat the suture with a coating that lasted from 7 to 10 days, which is plenty of time to prevent that bacterial colonization. The next thing we did was make sure it didn't interfere with the way the suture handled. So we did a study where we had surgeons grade the handling, the overall handling, and then very specific things like the ease of passage through tissue and not holding and not security. And bottom line is, in this blinded study, they couldn't tell the difference between Vicryl Plus and Vicryl. You see the ratings for excellent were actually numerically higher for Vicryl Plus, but statistically the same. So there was no difference in how the suture handled or what you're used to in the suture without the coating. So now we get to talking about what's the evidence that this makes a difference. We know we can coat the suture. We know that it prevents bacteria from colonizing from the in vitro data, but what type of evidence are the plus sutures supported by? In vitro studies, randomized controlled trials, meta-analyses, clinical practice guidelines, or all of the above. We'll just take a quick moment to let you vote. And it looks like everybody has kind of, I think we're good. You agree, it's all of the above. So we're going to get into some of that discussion about the clinical evidence now. So real quickly, the clinical evidence has been accumulating for 21 years at this point. And you can see in the graph that I've shown here, I just did a quick search in PubMed this morning and searched for triclosan-coated sutures, and they restricted it to clinical trials, randomized trials, or meta-analyses of randomized controlled trials. And there's more than 75 published studies at this point. So along all of those, and even in 2023, we're still seeing research, clinical research into plus sutures. And at this point, there's more than 43 randomized controlled trials. There's more than 21 separate meta-analyses of those randomized controlled trials over time. And at this point, there's more than a dozen clinical practice guidelines. I have to continually update this slide because people are still publishing studies. So I want to talk a little bit about some of those studies, but because I'm addressing, the Canadian audience here, I want to quickly go over the review that Cadith did in 2014 on plus sutures, where they had a number of research questions they wanted to ask, like what's the clinical effectiveness? Are there any adverse events? Where are the guidelines for using them? Are they cost effective? And at that point in 2014, they found that there was clinical evidence of different quality that suggested that it does reduce the antimicrobial sutures do reduce SSI incidence, and that they were probably cost effective from the healthcare standpoint, the payer standpoint, but they couldn't find any relevant literature on adverse events or the development of drug-resistant bacteria or guidelines. And that was 2014. Now, let's talk about the guidelines, which evidence-based guidelines are typically typically based on systematic literature review and meta-analyses. And here's 4 kind of high-profile evidence-based guidelines on since 2014, when the first CADTH review was done. So in 2016, the WHO came out with their first ever guidelines for the prevention of SSI. The Centers for Disease Control finally updated their 1999 SSI prevention guidelines in 2017. The American College of Surgeons updated their guidelines in 2016, and NICE in the UK, the HTA in the UK, they updated their guidelines in 2019. And all of them, when they looked at the data for triclosan-coated sutures, which was 100% Ethicon Plus Antibacterial Suture studies, they all came out with positive recommendations to consider the use of triclosan-coated sutures in reducing the risk of SSI. Now, the wording is different depending on the organization and in large part depending on the analysis they did. I want to point you to the WHO guideline, which very specifically said they suggest the use of triclosan-coated sutures independent of the type of surgery. Now, they said that for a reason. They didn't take that lightly. They analyzed not only a meta-analysis of the studies that they looked at, they did meta-regression against the type of surgical procedure in terms of they looked at surgical wound class. So they did a number of meta-regression analyses. So they did meta-regression and showed there was no difference in effect between the braids and the monofilament plus sutures. They showed there was no difference between the effect on clean surgery versus the other 3 surgical classes combined. And then for some reason, they looked at cardiac surgery versus other surgeries and abdominal surgery versus other surgeries. And in these cases, they found that there was no difference, that the triclosan coating was equally effective at reducing the risk of SSI across those different parameters. The other thing I just want to share with you is that across these 4 guidelines, obviously they contain way more recommendations than just looking at plus sutures, but the only thing they agree on is the use of triclosan-coated sutures. And in this chart I put together, green means that it was a positive recommendation, orange means it was a negative recommendation, in other words, a do not use, and gray means they either didn't look at that intervention or they said there wasn't enough evidence. So these interventions are everything that have to do with preparing the incision or treating the incision or closing the incision. And the only thing that they all agree on is the use of triclosan-coated sutures. So that brings us to the 2019 CADTH review of triclosan-coated sutures, although they called it triclosan as single-use medical devices. So I guess they were looking for all medical devices. Ultimately, they only found data on triclosan-coated sutures, and they looked at a health technology assessment, a systematic review, 6 randomized trials, and 1 large non-randomized study. And their findings were that the triclosan-coated sutures lowered the risk of SSI, and that the patients treated with them had better outcomes, or outcomes that were no different than patients treated with uncoated sutures. And the outcomes that were no different were things like wound dehiscence, quality of life, incisional hernia, readmissions, pain, those sorts of things. But they found some additional benefits with lower use of post-op antimicrobials, fewer instances of wound revision or outpatient visits, lower readmission rates, or evisceration. So I think the jury is in on the effectiveness of these antibacterial sutures in your overall approach to reducing SSIs. And these aren't the only guidelines. If you look at the country, the Germans, their CRINCO guideline, the Asia Pacific group, the Italian Surgical Society, the Thai Surgical Society, and even the World Society of Emergency Surgery all have their evidence-based guidelines, which include positive recommendations for the use of triclosan-coated sutures. And the most recent, actually, there's one more that came out recently that I haven't had a chance to add, but the penultimate recent meta-analysis was done by NICE in a coverage decision. So this wasn't an SSI guideline, but a technology assessment to make recommendation to the National Health Service as to whether they should reimburse for plus sutures. And they did a large meta-analysis of 28 RCTs on about almost 14,000 patients, 31 RCTs if you included the barbed sutures, the Stratifix line. And the reason they separated those was because we don't make Stratifix without triclosan, so they had to compare it to something else, so they didn't consider that as clean a comparison. They also cut the data in a number of different ways. They did subgroup analysis on adults, pediatrics, surgical wound classes, clean versus the non-clean categories, and whether they used fixed effects modeling or random effects modeling, which is a statistical method. there was no way they could cut the data that they didn't find a statistically significant decrease in SSI risk with the use of antibacterial sutures. So I think the evidence is in that it's something you might want to consider incorporating into your bundle. And if you do, here's a few recent bundle studies. Not surprisingly, these initial bundle studies are coming out in colorectal, where the risk tends to be the highest. Here's one from England where they implemented a 4-element SSI bundle. They used the chlorhexidine skin prep, dual ring wound protector, repeat dosing of antibiotics after 4 hours on the table, and plus sutures for mass closure and skin closure. They introduced their bundle in 2013 and monitored the results for the next 6 years before they published, and they found statistically significant reductions every year for SSIs in both laparoscopic and open or converted surgeries once the bundle was implemented. And when you're incorporating something into a bundle, you really don't know how much of your reduction is due to what intervention, because they're all working together. But what was interesting in this study is if you look at the green values, you see, although they're all less than the orange pre-bundle, in 2015, it was a little blip. And in reading the discussion, what they reported was that in their regular reporting, when they saw the rates increase, on one occasion, a spike was found to be due to an issue with the availability of the antiseptic sutures. So anecdotal support to my contention that plus sutures are doing something unique that nothing else in your SSI bundle is doing. So this was done in one hospital, and now this same group decided to take it across their 7-hospital system. It's exactly the same bundle. They were also testing a questionnaire. But the bottom line is that they wanted to see a 50% reduction in 30-day SSI, and they almost got there with this bundle. They got 47% reduction across their healthcare system. So something was working for them. And then the last one that I'll share with you was a 3-component bundle, again, in colorectal surgery, where they use triclosan-coated sutures for all layers of closure of the abdominal wall. Again, the chlorhexidine skin prep, and they warmed their insufflation gas and laparoscopic procedures. And again, they saw their SSI rates plummet from 27% pre-bundle to about 12.5% post-bundle. And again, that was across all surgical approaches, laparoscopic, open, and converted. So there we have, the implementation of from the recommendations, some guidelines into bundles. And the last thing I want to just mention is that if you're implementing plus sutures, it's very important that if you're using sutures for closure, use the plus sutures, use the antibacterial sutures at every layer of closure. I've seen studies where they use plus sutures in the deep compartment and not in the superficial compartment for whatever reason. I don't understand, because the uncoated suture is a risk factor. The plus suture down here, it's not a drug delivery device. It's not going to protect an unprotected suture. You're protecting the suture by using the antibacterial coating. Now, I would ask you, our last poll is, knowing now what you know about the strategy behind antibacterial sutures and the efficacy, how much more per strand do you think this antibacterial technology cost? So we'll open up the voting and we'll see what folks are saying. So we've got a lot of folks saying $1, some folks saying 10 cents, some folks saying $5. We'll let this go a little bit and see where we end up. So nobody seems to think it's as expensive as $10 a strand, but we're varying between $1 and 50 cents. All right, I'm going to end the poll and tell you that the correct answer is about 50 cents per strand. And obviously this will depend on your contracting and average selling costs and those sorts of things. But that's what marketing tells me is the average cost is about 50 cents per strand, which is only going to be a couple of dollars per procedure if you move to plus sutures. So the economics, you're not spending a whole lot more per procedure. I know if you upgrade to plus sutures in volume, your materials management might say, oh, we're spending more on sutures. But because this is a proven technology to reduce the risk of SSI, fewer SSIs, if you even prevent one SSI, at an average cost of thousands of dollars, that's probably going to make up for the cost of acquisition. Here's a meta-analysis, speaking of economics, done by Dr. Leeper, who did a meta-analysis of 34 studies in all types of surgeries. 20 of them were randomized controlled trials. The others were large cohort studies. This was using UK data. for the economic part. He used the NHS costs for managing an SSI and their cost for the differential cost of the sutures. And in his economic model, he showed that you saved about $113 per procedure by adopting Plus Sutures, because you were getting the risk reduction. In his calculation of all these studies, he saw a 39% risk reduction in SSI. And he also, backing up what I showed you earlier, found that this cost reduction held across all wound types, clean wounds, clean contaminated wounds, or contaminated and dirty wounds. And then secondarily, he did another economic analysis with US data on colorectal surgery only now. He looked at a database and figured out the incidence of colorectal SSIs. Again, I want you to notice that most of the SSIs are in the incisional space. And then in his economic model for the cost, he projected that adopting the antimicrobial sutures was going to save anywhere from $800 to $1,200 per patient. So again, there may be some incremental cost of acquisition, but you're going to reduce costs by reducing SSI. So closing, it's the only SSI bundle that addresses bacterial colonization of the suture, is supported by level 1A evidence, low cost, handles and performs just like non-antibacterial sutures, and it doesn't alter your care pathway, require in-servicing or any change in your surgeon behavior, and that's why I call it the invisible change. So thank you very much, and I will turn it over to the next speaker at this point. I think we're holding questions till the very end, is that right?
Yes.
Okay, I'll just transition. Thank you, Dr. Ovington. That was a wonderful presentation. I learned a lot in that presentation, and very, very good information. And so I think what we're going to do is we're going to kind of continue in the theme here. I'm going to connect some dots. But what we're going to talk about is adjunctive hemostasis products and kind of the science behind choosing the right product for the right patient for the right surgery. So I'm going to share my screen and we'll move on. And like I said, and like Dr. Ovington said, and Denise said, that we'll kind of defer questions till after my presentation, but look forward to a good discussion. Let's see here, we're just moving forward. Here we go. I'm coming to you from Nashville, Tennessee. I've got my boots on, but you can't see that on Zoom. But if I was there in person, you'd see my cowboy boots with my presentation tonight. But nevertheless, let's talk about how we choose adjunctive hemostatic products. So when we're in the operating room, we're facing bleeding, we're facing some challenging technical and operative situations. Obviously, it can be a little bit challenging in the heat of the moment, if you will, to kind of pick off the shelf a product that's going to work as soon as it touches the tissue. And so we're going to kind of talk a little bit about how we do that, and hopefully share with you some kind of best practices and hopefully even some guidelines. But before we do that, I want to take a step back and talk a little bit broader about the impact that surgical bleeding has on our operating rooms and our hospitals and even overall the health system. And this applies, of course, both the United States and in Canada. So I think this is universal information. But when we look at published studies about the extent to which operations of all specialties, not just cardiovascular, not my specialty, but all specialties across the spectrum, about 1/3 to 2/3 of cases have major bleeding events as part of the conduct of those procedures. And that percentage is a little bit higher than I would have guessed. I would have guessed maybe 10 to 15%, but I think it's a good teaching point that this happens more frequently. And sometimes when we have our heads down, focused on taking care of one patient at a time, we lose sight of the bigger picture here. Second of all, we know that those patients that do have a major bleeding event intraoperatively have kind of a rockier and more challenging postoperative course. And so we know that from the trauma and critical care literature, those patients are anemic, they're hypotensive, there's inflammatory cytokines involved. All those factors come together to increase the postoperative mortality in those patients that experience that major bleeding event. And then, of course, it makes sense that there is an extension to consuming more resources, and not just more resources in the operating room, but more resources throughout their entire hospital stay. And when we kind of get a kind of a healthcare economics kind of snapshot, if you will, and this data is in US dollars, but I'm sure we can kind of correlate that very well to Canadian dollars. But we chose a couple different procedures across different specialties and looked at the cost of those procedures when everything went smoothly. There were no major bleeding events, and it was just a routine procedure. And those average costs per procedure are listed there in the red box, kind of in the middle of the screen. In the box in the middle there, where there's not a red box, but in the column, excuse me, where we looked at those same cases when there were bleeding events as part of those operations. And you could see just kind of going down the rows and just kind of averaging, it looks like it's about $10,000 to $15,000 per case. So you could imagine the scale of this when you, and in a busy hospital, if this is, 5 cases a week, 10 cases a week, you could see how that cost adds up. And then you could even see how that would multiply across an entire kind of country or health system. And so I think we are talking about a huge opportunity to have not only a clinical impact, but also a kind of an healthcare delivery impact. We're not qualifying different types of hospitals, and we're not judging one hospital versus the other. We're not judging one surgical team versus another surgical team. This is across all specialties, all surgeons, and all hospitals. So it doesn't matter if you're a major teaching hospital or a community hospital. We know that our patients bring to us, before the scalpel ever touches the skin, increased risk for surgical bleeding because of their comorbidities. And for example, there, as you can see, comorbidities such as uncontrolled diabetes, obesity, and cancer naturally disrupt the clotting process. So like I said, before the scalpel even touches the skin, we know that there's an increased chance that those patients that have those comorbidities are going to have a risk of bleeding, regardless of whether or not they're having a minor procedure or a major procedure. And furthermore, of course, we're operating on older patients, and those older patients also have those comorbidities, but also on top of that, of course, decreased tissue integrity and all the other factors that go along with the older demographic. Layered on top of that, of course, are that more and more patients are prescribed anticoagulation medications for a host of other, kind of comorbidities, if you will. But on average, if we look at the data, it's about 10 to 25%. I think by now, maybe even up to 30 to 33%. So almost a third of our patients may be on anticoagulation. And for routine, straightforward cases, elective cases, we have the opportunity to hold those medications preoperatively, bridge them, and then operate when their coagulation profile, is back to normal, do the operation safely, and then restart those anticoagulation medications in the postoperative period. But of course, for urgent and emergent cases, we don't oftentimes have that luxury, and we're forced to operate in the face of those medications. So that obviously increases the risk of bleeding. And of course, you all know, and we all know from kind of just taking care of a lot of patients and being involved in surgeries, that we're not talking about one type of major bleeding event. It could come from a range of different pathophysiologies, everything from capillary bleeding and venous bleeding, which would be that kind of darker color that we visualize in the operating room. But it could also be arterial, and could be a small artery or a large artery, which would be bright red, sometimes even pulsatile in nature. And of course, we're not trying to change fundamental surgical principles and techniques, which are the primary methods. And those primary methods, of course, we use on a day-to-day basis for every type of procedure that we do. So it's either mechanical, such as sutures, ligating clips, staples, clamps, and even just manual compression, as well as energy methods to control the bleeding. But there will be a subset of patients where we've really maximized all of those first line, front line, standard operating principles, where we've maximized that, and there's still some ongoing bleeding. So there's a subset of patients where there will be some ongoing bleeding challenges after we've done everything we can. And that's where we're focusing tonight, about how we would choose the right product to add to that procedure, apply to that bleeding site, to control the bleeding quickly and efficaciously. This is an example of what happens when we flip the script. And what I mean by flip the script is we do apply the right adjunctive hemostatic product, the topical product, quickly and efficaciously for those patients in those situations where there is a major bleeding event going on. We can decrease the blood transfusion requirements by 8 to 40%, which I think is a pretty big deal, both clinically as well as from a healthcare economic standpoint. We can lower the length of stay or shorten the length of stay even after they leave the operating room by 1 to 4.4 days. So there's a beneficial effect not only in getting the patient safely out of the operating room, but in getting them even home and discharged quicker and sooner. As you can see there for the third line, that we can certainly shorten the operating room time. That's important when we're trying to turn cases over and we've got maybe 2, 3, 4 cases stacked back to back in the operating room. And if we could kind of shorten the duration of a case by choosing the right product, that certainly adds up throughout the rest of the day. And then that last line is very interesting. There's data, published data, to show that when we use certain products such as fibrin sealants, we can actually lower the readmission rate even after they're discharged. So something that we're doing in the operating room can impact the care and the quality that patient has for the next 30 days. And we know readmission rate is a quality metric that all of our hospitals and service lines follow. So I think that's pretty substantial and eye-opening when you really see that data. I want to kind of briefly transition here away from the kind of larger picture and focus more on what's really going on at the clinical level. And this is something that we all know. We've been tested on this many times. We kind of live and breathe it every day, if you will. But I just want to kind of quickly revisit the hemostatic cascade and start to connect some dots with where these products work and how they work. And so when we kind of talk about different categories of products, before we talk about the names of the products or, kind of different types of products, I want to kind of talk about different kind of broad mechanisms of action. And the first category of products are topical absorbable hemostats. They interact at the platelet plug formation level. They provide a matrix to enhance and accelerate the natural, platelet plug that forms. So that platelet plug is going to form, but the topical absorbable hemostats accelerate that and make it happen faster and therefore decrease the amount of bleeding that goes on. The next category of products are active hemostats, and they work a little bit downstream within the kind of hemostatic cascade at the fibrin clot formation level. They really accelerate that fibrin clot, and because it's a kind of a next level beyond the platelet plug, it actually is kind of a stronger impact in terms of addressing the impact of bleeding in the operating room. The third category is very interesting. It's combination products. And so some people got really smart and some engineers they said, hey, why not combine features of topical absorbable hemostats and active hemostats all in the same product? And that's a combination product. So it has features and mechanisms of action of both of those products all in the same product. So when you open up a combination product, you're getting something that works at 2 levels at the same time. And your intuition is correct that if a product works at 2 levels within the hemostatic cascade simultaneously, it works stronger, quicker, and better and faster than a product that works just at 1 level. So therefore, you kind of reserve that for your more extreme situations, if you will. The next category of products are synthetic sealants. We've listed them here visually outside the hemostatic cascade. The synthetic sealants certainly help in controlling bleeding, but they don't interact, augment, or accelerate a natural clotting process that is going on within the hemostatic cascade. So they're inert. They're kind of like caulking. They plug some holes to help stop the bleeding, but they don't upregulate or accelerate those natural processes that are going along through that hemostatic cascade. And then finally, the last kind of broad category are called sieves. And sieves, once again, we've listed them here outside the clotting cascade because they don't interact or accelerate the natural clotting factors that are there. They just basically concentrate the factors together. So they absorb fluid and bring those factors together to help kind of form that process, but they don't upregulate anything or accelerate anything. So let's move on to the technology and kind of make really good use of the rest of our time. And I'm certainly looking forward to your questions and comments. but it's confusing. There's a lot of products on the shelf. There's a lot of different names to these products. And like I said, in the heat of battle, sometimes it's really hard when kind of there's a lot going on in the operating room to kind of choose the right product off of the shelf, put it in the patient, and have it work correctly and effectively. To do that, though, to kind of cut through that confusion and try to make sense of all of the different kind of products that we have at our disposal, we tried to kind of put together, or we did put together a study that tried to identify different universal bleeding situations that go on in operating rooms all across the country. And so, for example, can we differentiate the types of bleeding situations that may be going on in a neurosurgical OR versus an orthopedic OR versus a cardiovascular or GYN OR? There's got to be some similarities there kind of at a high level. And if we kind of find those similarities, we can then kind of connect that to the different products. And so to do that, we engaged 11 different specialties to try to make this as broad and multi-specialty as possible. We engaged 450 surgeons across those 11 different specialties. And we asked them to submit to us operative reports of patients where they had major bleeding events recently in their practice. And so we got 7,800 operative reports. We read them all, we tabulated them, analyzed them, and we looked for kind of common features. And invariably, the two most common commonalities across those cases were the site of bleeding and the situation of bleeding. And we all know that. That's kind of common sense, right? Because we know that bleeding on the heart is different than bleeding on the liver, which is different than bleeding, in the pelvis or retroperitoneum or even the mesentery. And likewise, a redo surgery has different bleeding risk than a primary surgery, and a laparoscopic or robotic surgery has different risk than an open procedure. And when we put it all together, we identified 5 different, and we call them universal situations. So once again, it doesn't matter what type of operation is going on, in what hospital. You could walk in that OR, and if there's bleeding going on, you could literally classify it into one of these 5 different categories. And I want to kind of walk through them real briefly here. The first category is continuous oozing. This is the most common situation that we run into. It's a situation that I call it nuisance bleeding. It's where you hold pressure, you look at it, you remove your sponge, and there's still some ongoing bleeding despite holding compression. And you've put a suture in it, you've cauterized it, and it's still just kind of ongoing. That's why I kind of call it nuisance bleeding. The second category is problematic bleeding. And just like its name implies, it's a little bit more aggressive bleeding. It's something that you've got to address then and there because there's a fair amount of bleeding, blood loss going on. The third category is very different. If the first 2 categories were kind of like minor bleeding versus major bleeding, this category has nothing to do with intensity, but it has everything to do with how easy or difficult you can identify the source of bleeding. So think of those cases where there's some bleeding going on, you adjust the OR light, you adjust the tractors, and you're still kind of suctioning up, and you can't quite pinpoint and identify where that bleeding is coming from. You can see the effects of the bleeding, but you can't pinpoint where to cauterize, where to put a suture on, and so forth. So it's in a really hard to reach or even hard to visualize area. The next category is also different. It's potential rebleeding risk, and it also applies more to what happens after that patient leaves the operating room. Certainly, we're concerned about making sure everything is hemostatic before we close up, but think about the postoperative situation where we have to restart anticoagulation in the early postoperative period. Maybe somebody has chronic AFib or a DVT where they're on anticoagulation. When we restart that anticoagulation, we're always concerned that we may stir up or increase the risk of bleeding well after they've left the operating room. And then finally, the last category is pretty self-explanatory. It's a high pressure major vessel bleeding. It's pretty obvious. Everybody in the room knows it. And it's where, we've got to kind of get that fixed, of course, before we leave the operating room. So out of those 5 different situations, we can connect each of the different products within the Ethicon portfolio about where it is ideally aligned with each of the different kind of scenarios. This is kind of the great cheat sheet, if you will. This is a reminder, and we actually have this up as a wall chart in our surgical lounge so that everybody that comes in the surgical lounge sees this on the wall as a reminder of, one, how important it is to understand and address surgical bleeding, but two, a reminder of which products we choose and why we would choose one product for one situation versus another. And I just want to spend just a minute or two talking about the different kind of products within the Ethicon portfolio and touch on them. And we've linked each of these products that we're talking about here with each of the different scenarios. So the first example and first product we're going to talk about is Surgicel, but as you can see at the top of the slide, Surgicel is really great for continuous oozing situations. We all know Surgicel. It's been around for many, many years. It's a global brand leader. But what you may not appreciate is Ethicon has really innovated off of Surgicel Original into second, third, and fourth generation Surgicel products. And so when you compare the efficacy of those later generation products versus Surgicel Original, they actually have an increased clinical benefit. There's 25% less product usage, 38 to 52% less transfusion costs, and even decreased length of stay costs associated with that. So some of those later generation products are Surgicel Snow and Surgicel Fibular. But the most recent addition to the portfolio is Surgicel Powder. It's basically Surgicel that's broken up into very, very small pieces and allows increased surface area for activating that platelet plug. It has 89% faster time to hemostasis than another competitor product on the market called Arista. But I want you to focus on that next to last bullet point, which is really interesting, is that this applies not only to Surgicel Powder, but to all of the Surgicel products on the market, in that they are bactericidal to gram-positive and gram-negative organisms. And so we just learned about surgical site infection from Dr. Ovington and the kind of the benefits that some of the Ethicon products have, some of the sutured products. But here, we've got an additional product that doesn't have any antibiotics or any special substances added. But what happens is the Surgicel in itself operates at somewhere around a pH of 2 to 3. And so that low pH, when the Surgicel product touches the tissue, creates a low pH environment, which is bactericidal. So I think that's very interesting and compelling for all of the Surgicel products. Here's an example of applying Surgicel powder to a continuous oozing situation. And you can see here, we can put a very thin layer of it. We can build it up and focus it where there's maybe more bleeding within the operative field. We let it sit up for about 2 minutes, just kind of let it kind of do its thing. And the most important thing is to irrigate off, as you'll see here briefly, with some just saline, just irrigate off that excess powder. That excess powder is not helping clinically, but if you have any tubes or drains or chest tubes in place, that excess powder could prematurely clog the drain. So it's important to get that off. Once again, it's not helping with maintaining hemostasis. The next product is Everest. It's great for those problematic situations, which is kind of that second category. Everest is one of those combination products. It has features of topical absorbable hemostats and fibrin sealants and fibrin clot formation, all in the same product. It's really great. You can just kind of open the product up. It doesn't require any prep. There's two sides, a powder side and a wavy side. The powder side goes down to the tissue, hold pressure for 3 minutes, and then you've got hemostasis. And once again, the clinical data and the healthcare economics associated with that are really compelling. The next product is Surgiflow. And once again, you can see at the top of the slide, we've transitioned to difficult to access bleeding. And Surgiflow is really great for those kind of hard to reach areas, because the flowable gelatinous matrix can kind of get into nooks and crannies that we can't see or even reach. And once again, the clinical data that's been studied and published is quite robust. Here's an example of using Surgiflow for an injury to a spleen. So this is a spleen in one of our animal models, but we can just basically take the delivery cannula off the Surgiflow syringe and instill this directly into the tunnel. So you can imagine, we can't see where the bleeding is coming from in the tunnel, but you can imagine Surgiflow getting into all those nooks and crannies and controlling bleeding and saving this spleen. The last product I want to talk about, and then we can kind of turn it over to questions and comments, is VistaSeal. And VistaSeal is a product that I've had a lot of success with in my cardiovascular cases. Of course, you can use it in a whole host of other types of cases, but personally, have a lot of great stories and success stories with VistaSeal. It's a fibrin sealant. It's a topical product that we sometimes call clot in a bottle, because it can form clot even in the face of someone that's anticoagulated because of the mechanisms of action. I use it to control needle hole bleeding, but it's also great for broad surface diffuse oozing situations. So it's a really, really great product, as I said. Here's an example of using it for the spray technique, and I'll just briefly show you. It can be sprayed. In this particular design, we don't need excess equipment off the operative field. So no tanks, no tubing that has to be prepared or passed off the field. So it's just all self-contained. We can cover a broad surface area. And then for my cardiovascular cases, I use the drip technique. I can localize that, just unscrew that airless spray tip, concentrate it directly on the area that's bleeding, and really focus it, like I said, on a particular suture line or a particular area of the operative field. So I know it's been a rapid kind of presentation here, but I had a lot of information I wanted to share with you. But at the end of the day, really hope you've found this helpful. But and once again, at the end of the day as well, is that I really want you to appreciate we do have an algorithm and kind of a science, if you will, about how we would choose one product versus another and really align that for each individual patient. So I'll pause here and turn it over to Denise, and welcome your questions and comments. So thank you so much. And I will stop sharing too. If you can give me a second.
Thank you. Thank you so very much, Dr. Ovington and Dr. Wheatley. Lots of information to think about, definitely well researched, and the literature is very clear in terms of the benefits for patients in the immediate short term and then long term. I'm really interested in the SSI piece combined with the hemostatic agents and how we can really leverage that bactericidal in addition to wound closure for patient benefit. I'm not sure if everybody's able to use the Q&A box, but please think about your questions. I'm going to open them now and start to ask whatever is there. So the first question is, with regards to the clotting cascade, would you suggest a combination product be beneficial in the use with bilateral mastectomy? I think that's for you, Dr. Wheatley.
Yes, thank you, Denise. Yes, that's a great question. Thank you so much for asking that. You know, the combination products are really reserved for really challenging situations where it's pretty substantial bleeding. You've got a lot going on, and you know you've kind of really maximized everything that you have. For bilateral mastectomies, I would I recommend maybe starting with you know, a Surgicel powder that could kind of cover a broad surface area, or even VistaSeal. So those would be kind of my two starting products. Certainly, if there's some exceptional bleeding going on throughout either one side or both sides, you could certainly consider Everest or a combination product. But I probably wouldn't start with a combination product. I probably would start with one of the products I just mentioned and kind of see what goes on and then go from there.
Thank you. And next question is there any risk of these hemostatic products to migrate in the vascular system? So perhaps maybe even I could add a little bit to that around contraindications might be relevant at this point.
Yeah, thank you. That's a great point, Denise. And thank you for that question as well. They don't generally migrate in the vascular system. Now, I can't say, that applies to every, universal situation, but you can imagine maybe applying maybe VistaSeal, as I said, on my suture lines while I'm doing a open heart surgery. And, that patient's on cardiopulmonary bypass, is on the machine. There's obviously some concerns there. I have not had any issues with it. And we're talking about a very thin layer that's superficial. And so the chances of the product kind of getting into the vascular system are minimal to very rare. So in essence, the answer is no when they're applied, kind of using the appropriate, indications as well as the labeling for the product. So we just want to make sure you use it on label. And to Denise's point, I think that's really great, is what are some of the contraindications? There are some swelling components to these. They do absorb fluid from the surrounding tissue. So if you use them in really tight areas, maybe a spine surgery, maybe some unique situations within neurosurgery, and some other scenarios, you might be concerned about some of that, the impact of that swelling. Once again, the more product you apply, the more swelling you're going to have. So always want to use as minimal of the product as possible, but there certainly are some anatomic situations where you'd want to probably stay away from those.
Thank you. Great answer. Next question is, sorry, I have to keep up. I'm new at moderating, so bear with me. Do any of your products need to be refrigerated or frozen? And could you explain the rationales for each?
Yes. So the VistaSeal does need to be frozen. It's the only product that requires that. And some of the biologics in that syringe do need to be stored just from preservation standpoint. They can be thawed pretty quickly. You can kind of put it in some kind of tepid water. So you don't want to kind of put it in scorching hot boiling water, but you can just put it in some kind of room temperature water, and it thaws pretty quickly. You do have to understand that in the heat of battle, if you're asking for example, VistaSeal, there would be a little bit of a delay in terms of getting it out of the freezer, thawing it, but it's just maybe 10 minutes or so. And for example, for my cases, I kind of anticipate sometimes where I'm going to need it. So if I start to see the situation going south, or I feel that this might be a situation for VistaSeal, I'll call out and alert my OR team to try to kind of start that process before I want it in my hand, if you will, to kind of anticipate that and kind of avoid some of those delays. But VistaSeal is that product that does have that feature.
One more question around that answer for VistaSeal. Is there a maximum amount of time it can be on your table in case there's a delay?
Yeah, that's a great question. Once it's thawed, you can actually use it for, I believe, 18 to 20 hours. So it can certainly, it's not going to expire during that case unless it's a marathon case, an exceptional case. And even to that point, that's a great point, Denise, is that even if it thaws in room temperature without opening up the sterile package, you can use that within the next 24 hours. So the next operative day, if somebody wants to use VistaSeal, it's still good to go, even though it's been thawed and out of the freezer. So there's really important considerations. And I've seen many times where surgeons change their mind. Oh, we got it controlled. We don't need that right now, or whatever. And the OR team just kind of puts it there in the refrigerator and brings it out the next day.
Thank you very much. Let's look at the questions again. Other than the product makeup, what would be the main indication for use of the surgical powder versus Surgifoam powder?
That's a great question. There's obviously a lot of different considerations, but the Surgicel powder has kind of a better mechanism of action, if you will. It does accelerate that platelet plug more rapidly and effectively than the Surgifoam powder. So it's more effective clinically. Would be my response. And then there's obviously considerations in terms of cost. There's certainly each of these products kind of have a different cost associated with them. But it's not just about the product cost, it's about the clinical overall cost associated with the efficacy too. Because if you open one product and it marginally helps, you may have to open a second or third product just to get the same hemostatic effectiveness as opening up one product. So you may actually kind of save costs by choosing, one product versus another. In addition, there's the whole transfusion cost, OR time. So there's these exceptional factors that kind of come into play when you're choosing one product versus another. But I've had, as I said, great success with Surgicel powder.
Apologies, I'm typing answers as we go so that they're there for future reference. Another question from Elizabeth. Thank you. The plus sutures, has there been reports of sensitivity from patients post-operatively or post-use? Wondering if Dr. Ovington can answer that question.
Sure. No, there haven't actually. So technically triclosan is not an allergen, so it's not a protein. It doesn't complex with haptens. And specifically, I was the medical director for these products for about 16 years, and I was able to compare any reports of skin reactions between the base sutures, say Vicryl, PDS, or Monocryl, with Vicryl Plus, PDS Plus, or Monocryl Plus, and there's never any differences. So we have not seen any adverse reactions, sensitivity, hypersensitivity, or otherwise, and there's not been those types of reactions reported in the clinical trials either.
Excellent. Thank you very much for that. I am wondering if there is in the future with hemostatic agents, although they are bactericidal, if there is any need or merit to include any type of antimicrobial product. What are your thoughts on that? Would that complicate the formation of a clot according to the hemostatic cascade? Maybe you could share your thoughts on that in terms of the combination of antibiotics and or products to reduce the SSI beyond suture use in a hemostatic agent, appreciating that they do have bactericidal or static properties.
Well, and that's only for Surgicel. So I think with adding antimicrobials to antiseptic product or to hemostatic products, you're going to have tough choices, right? Between, as we mentioned with antiseptics, they can be equal opportunity cell killers, so you don't want to have any detrimental effect on angiogenesis or those sorts of things. But I think, with Surgicel, because it's a pH effect, but I don't think, the only combinations like that I've seen that you're probably familiar with are the collagen gentamicin sponges. But other than that, I don't think there's a real pressing need for a combination antiseptic hemostat. I don't know. Dr. Wheatley, your thoughts on that?
I agree, Dr. Ovington. Thank you. I'll say that, of course, any kind of combination would be off-label, of course, for the products. They're not studied or indicated for that. But that doesn't mean that a lot of people haven't tried it. I'll say, in my world in cardiovascular, of course, we're all a little bit paranoid for deep sternal wound infections, and a lot of surgeons, maybe not evidence-based, but do feel that kind of putting some antibiotics on the sternal edges after the sternotomy and before closing helps. Once again, no study has kind of done a randomized trial on that. So, but I have had some surgeons try to mix vancomycin powder with Surgiflow, and you kind of create a ball that you kind of massage into the sternal edges. Once again, off-label, but I have definitely seen surgeons do that, and that's kind of where I've seen some kind of combination effects.
That rings a bell. I think I have seen some of that. I'll call it MacGyvering, but with all the best intentions and minimizing risk for patient for sure. I think, comorbid patients, as addressed in your presentation, you treat them separately with antibiotics, et cetera. So I just thought I'd ask the question to see if there was something coming down that maybe we could think about. I have a question that I put in the chat only because I couldn't get it in the Q&A because I'm a panelist, and it's for Dr. Ovington. There was so much literature around the benefits of using triclosan in sutures, and it makes me think, with the cost of the suture being so low compared to the cost and actually the harm to patients, long stays, et cetera, why are we even making sutures without it?
Well, it's a great question, and you can understand it's a question we've asked ourselves, and I'll tell you that, and I don't think I'm revealing any secrets. Ethicon is moving to only making triclosan coated absorbable sutures. Now, we can't obviously come to your hospital and say, okay, we're done. But that's the movement. We've seen organic movement towards that. I know in Ireland, they only sell the triclosan coated ones because the adoption was at a point where, we were seeing less movement on the non-triclosan coated. But it definitely makes sense when we see, and again, the vast majority of these studies have been Vicryl plus versus Vicryl, monocryl plus versus monocryl. So we ask ourselves, why are we still making monocryl? And as I said, any new sutures that are coming out, for example, when the barb sutures came out, they all came out with triclosan coating. So Ethicon is committed to that. The market kind of has to catch up to that, but it's definitely a question that more and more people are, it's kind of that V8 moment. It's like, oh, okay. But believe it or not, there's still folks who don't understand the benefit or aren't aware of the evidence base for triclosan coated sutures. So we're still, moving the needle.
And, in the US, more so than Canada, patients are paying for their health care. And so it would stand to reason that they might want to have something that's going to minimize hospital stay and all of the complications that we talked about, but also standard of care, right? What is the gold standard? So I think those are relevant comments, and hopefully it will get there in time as things evolve. Couple of other questions here that are in the chat. I'm going to put this one back to Dr. Wheatley. Why do some hemostatic agents need to be refrigerated or frozen?
It's a great question. Some of the products, such as fibrinogen and other factors, do need to be, that are kind of in those products, just have to be frozen. They can't be stored. We haven't found a way, or Ethicon hasn't found a way to keep them stable at room temperature or other temperatures. So it's just a way of making sure that the product is biologically active and viable at the time of use.
Thank you. Another question in the chat, if I may refer to that, from Monica. What's the best sealant or sealer for patients that are not consented for blood or blood products?
That's a great question. To be honest, that's worthy of a whole presentation in and of itself. So I don't think I can do it justice. But I will say two comments. First, the first response would be, there might be some concern about thrombin being applied, particularly human thrombin in the product. So if you have Surgicel or any of the Surgicel products, Everest, those don't have human thrombin in them, and would be effective, but at least substantially. And so the other products, though, I will say, and this kind of goes around maybe to the Jehovah's Witness population, and who obviously have concerns. And once again, this is a whole nother area, and this is something that I've spent a lot of time and taking care of a lot of Jehovah's Witness patients. First of all, it's an each individual patient decision. So even though someone may be a Jehovah's Witness patient, they have the choice and the freedom of choice to choose and make anything that they feel is best for them. So they may, even though they're Jehovah's Witness, may choose to use a product once you've explained the benefit of them and the risk and so forth. So once again, it's an individual product. And second of all, I've had this discussion directly with the Jehovah's Witness organization and the whole community. And their reservations about blood products are about transfusion, intravascular administration of human products. And the products we're talking about here are obviously topical, and they don't by nature get integrated into the intravascular space. And so in theory, and once again, this is from the Jehovah's Witness leadership, if you will, they actually don't have any reservations, broadly speaking, with any of the products. Now, once again, you may explain the products, and some people may say, I don't want any sort of human thrombin in the field, and that's fine too. But it's a very, very Pandora's box question, but I hope that kind of touched on it enough.
I agree. It is a large topic to work through, but your answer was just great. Thank you so very much. We have another question from Elizabeth. ASA follow-up on that question. How can we encourage the use by surgeon in the various operating rooms? I'm not sure, that's a bit of a strange, the way it's worded. How can we encourage the use by surgeons? I think that's around the suture use. Elizabeth, can you get us a recommendation? Yeah, sutures, I believe. That's around sutures. Yes, plus sutures. Thank you, Elizabeth. So that's one is for Dr. Ovington.
Yeah, I think most of the issue is around awareness, of the evidence base and the different evidence-based guidelines and the different analyses that have been done. So here's a common question I get. They'll say, well, has it been used in transplant surgery? Has it been used in XYZ surgery? And obviously there's way more named surgical procedures and surgery types than there are surgical wound classes. And bacteria don't know the name of the procedure, right? The mechanism of action of plus sutures is the suture surface is protecting itself from being that nidus for infection. So the mechanism of action is procedure agnostic. So normally I would say, well, it doesn't matter, and it doesn't matter, but maybe the evidence base would be, I showed you the meta-regression that NICE did and that Leaper did on surgical wound classes. So for hundreds of surgical procedures, there's only 4 surgical wound classes. So what I would say was, what surgical wound class are you talking about? Because the technology has been shown by meta-regression to work across all surgical wound classes. It works just as well and clean as dirty wounds. So, and that's the thing that makes a difference with surgical site infection, the surgical wound class, not the name of the procedure. So that's why I'm surprised to continue to see in 2023, 21 years after the first plus sutures, people are still doing RCTs. I think the mechanism of action of the way this works has been established. I don't think we need to do more RCTs on antimicrobial or plus antimicrobial sutures. I'd like to see more of the bundle studies that I presented where people saying, yeah, I'm using it and here's what I'm seeing in combination, because we always use things in a bundle, right? You never just do one thing. So I think just awareness of the evidence base is the way to go.
Thank you very much for that thorough answer. I see one more question here, and I have to bounce it back to Dr. Wheatley, and it's around some of the sealants in terms of, first part of the question was, what's the best sealant to use for patients who are not consented for blood, which you've already answered. But in addition to that, what if patients do not want to have any animal products? So I'm thinking religious. You mentioned human components. Any animal components in the products that you mentioned earlier?
Well, that's a great follow-up question. Thank you, Denise, and thank you, Monica, for your question. At the end of the day, the Surgicel family of products are plant-based. And so that are the most kind of broadly received and less contentious, if you will. And once again, it's all an individual patient. So at the end of the day, if some patient was very adamant about after you explained everything, I think that's where any of the Surgicel products would be appropriate and fine.
Thank you very much. And I think I have a hand up. I'm just typing that answer in. So we have that answered. I think I see a hand up by Nicole Sullivan. Let me see if I can unmute you for you to be able to ask your question. Okay, Nicole, just give me one moment. There you are. Okay, Nicole, you're open to the floor.
Oh, sorry, Denise, I hit it by accident.
Oh, that's okay. Nice to see your name. Sorry, I'll mute you again. I used to work with Nicole, so now she's in a different city, so I recognized her name. I'll just check if there are any more questions here. Just some thank yous and some very positive comments for the presentation tonight. So much to think about. I think I will have to dive into more research on Jehovah's Witness and some of their preferences. Although I really like what you said about individual patients making the right decision for them at that moment in time. It would like to advocate too that the suture use in our ORs could really make a difference for our post-operative patients. And I guess spreading awareness, to your earlier point, Dr. Ovington, is the way that we as nurses can help to spread the news. So I really do appreciate you both taking the time to share your knowledge and expertise with us this evening, and for Ethicon J&J for hosting tonight's presentation for our members. We've had upwards of 50 people on this evening, so we're very pleased with that number. And final call for any questions before we end the webinar this evening. Okay. And you're very welcome. I see lots of thanks coming in. And I really want to encourage those attendees tonight to remember next month there will be another topic. I won't advertise it tonight. This is all about Ethicon's great support. So thank you for supporting our organization, our membership, and the education to promote best outcomes. I think I have certainly learned a lot, and I'm sure my fellow members have as well. And thank you once again for everything this evening. And at that, we will call our webinar to a close. Thank you again. Stay safe, everyone.
Pleasure.
Good night.
Good night.